Thank you, Ajit, for a nice introduction. And a warm welcome to all the delegates who have logged in for this evening's webinar. And I take this opportunity to thank the entire team of Sanofi for hosting this webinar today and giving us opportunity to share our knowledge regarding the combination treatment of type 2 diabetes mellitus in our day-to-day practice. And we all know that diabetes mellitus is a progressive disease, and as the year passes, there is progressive decline in the beta cell function, and which leads to a progressive rise, or rather deterioration of glycemic control, and requires the addition of sequential addition of one after another group of oral anti-diabetic drug. And if sometimes the type 2 diabetes mellitus patients are also complicated with having other concurrent illnesses like diabetes, hypertension, dyslipidemia, coronary artery disease, hyperuricemia, and so on and so forth. So many concurrent illnesses, and this also requires treatment. So all this leads to a polypharmacy and addition of many pills to treat all those individual conditions and type 2 diabetes mellitus itself. So this polypharmacy and introduction of too many pills leads to a problem of adherence in the treatment, and even in countries who have best Medicare, best government sponsored healthcare system, even in them the adherence is only up to the tune of 39% only. So you can see that the polypharmacy or additional pill burden leads to lesser degree of adherence of the treatment. And to combat this problem or to overcome this problem, the fixed drug combination offers a plausible solution. And fixed drug combination, as the US FDA has defined, that two or more drugs may be combined in a single dosage form when each component makes a contribution to the claimed effects, and the dosage of each component is such that the combination is safe and effective for a significant patient population requiring such concurrent therapy as defined in the labeling for the drugs. And we know that this fixed drug combinations are being used in many of the chronic medical conditions, and we use this FTC as an antiretroviral therapy in HIV/AIDS. We use anti-tuberculosis drugs in the fixed drug combinations. Likewise, we have asthma management also in this fixed drug combination. We have anti-cancer therapy in the fixed drug combinations, and so antihypertensive drugs also have this fixed drug combinations. So this fixed drug combinations offers a plausible solution to reduce the problem of adherence. And the salient or rather happy point is that the addition of this fixed drug combinations has brought about a 26% decrease in the risk of non-compliance compared with the free drug component regimen. So this is quite important, and when we want to achieve a better compliance in our patient population, then fixed drug combination is a need of the hours. So in today's discussion, we shall be talking on this issue of fixed drug combinations, their rationales of using, trends and benefits of combination therapy in diabetes, guideline recommendation for the use of combination therapy, available classes of fixed dose combinations in India, and measures to improving rational use of fixed drug combinations we shall be talking on these points. And we know that in India we have a tradition of we have a good tradition of using, and we have good fixed drug combinations to treat the type 2 diabetes mellitus patients, and they have successfully brought about a reduction in the glycemia and bringing our patient to target level of glycated hemoglobin in a large population. So fixed drug combination are the need of the hour, and we shall be seeing in next 30 or 40 minutes regarding the various aspects of the fixed drug combinations, basics and rationale. So basis of fixed drug combinations, as I have already alluded to earlier also, their combined effects of the drugs leads to so many of positive effects, and we know that if we add more than one drugs, their effects may be summated. And summation means that all the drugs that we have added act on the different targets but bring about the same effect. And additive effect means that the both or two or more drugs act on the same target and they produce a addition of this desired effect. And likewise, synergism is when both these drugs brings about a rather increased effect of the desired treatment goal. So this is synergism, and sometimes these combinations may produce antagonism, which is not desirable in our treatment plan. And this antagonism is when both the drugs, that is two or more drugs, when added, they bring about a reduction in the desired effect. So these are all mechanism of actions of combination of the fixed drug treatment. And whether a combination is irrational or rational is based on three key factors. And whether the components are acting by same or different mechanisms, this must be kept in mind. Whether the pharmacokinetics of the components are widely different or not, and whether the combinations have supraadditive toxicity of the ingredients or not. Or not. So this is important, as the toxicity should not be added. Each individual drug's toxicity should not be added. And rationality of fixed drug combination can also be based on the fact whether treatment guidelines support their use in the concerned disease or not. So we should need the backing of the guidelines to promote fixed drug combinations. And we all know that there are merits and demerits of these fixed drug combinations also. So talking about the merits of fixed drug combinations, they improve therapy adherence, as I have told you, that this compliance is increased rather by 26%, and treatment outcome, and they reduce pill burden, they reduce medication error, and the cost is also cut down, and there is simplified dosing with only one expiry dose. And talking about the demerits of the fixed drug combinations, dosing flexibility is not there, as the drugs are in the fixed formulations, fixed strength. So we are not in a position to modify their doses. So this dosing flexibility is lost, and risk of drug interactions leading to altered therapeutic effects. Sometimes different drugs have drug interactions and they lead to a alteration in the therapeutic effect. And sometimes their pharmacokinetics may be incompatible to individual components, so this also should be kept in mind. And need to discontinue if a patient is allergic to even one component of the FDC. So this is also a very important point to note and keep in mind while using FDC, that if your patient is allergic to any one of the component in a fixed drug combination, then you may have to abandon this fixed drug combination altogether. So this is regarding this rationale of using these fixed drug combinations. And what should be our approach while treating a case of type 2 diabetes mellitus with aim to reduce this glycemic burden and bring our patients to target. So current status of glycemic control and reluctance to increase pill burden. We know that the global average for glycated hemoglobin level in diabetic patients are only 9.5%. So despite our best efforts, we could only bring this glycated hemoglobin level continues to be at a level of 9.5%. And we know that our target for this effective glycemic control is 7 or less. And the reason for this not reaching to the target is reluctance to increase pill burden. We know, we have already said that diabetes being a progressive disease, there is progressive deterioration in beta cell function, and there is insulin resistance also. So to overcome all these effects, we have to add different medications having different pathogenetic or pharmacokinetic effect, addressing different pathways to control glycemia. But there is a reluctance to increase pill burden, which leads to not achieving the patient to the target. So there are patients concerned regarding this cost and convenience and side effects when using FDC. And physicians' concerns are also there, because a large chunk of the patients indulge in doctor shopping. So this is also to be discouraged. And doctor shopping is a phenomenon when a patient keeps on frequently changing, and this changing their healthcare providers. And so their fine-tuning controls are sometimes delayed and lost. So this factor is also very important. We know that monotherapy, we earlier used to start with monotherapy, and we know that in management of type 2 diabetes mellitus, metformin used to be the initial molecule, if at all the patient was not intolerant to use of metformin, or the patient was not controlled with metformin. So, but we know that there are several challenges with the use of the monotherapy, and monotherapy is unlikely to adequately control type 2 diabetes mellitus in the long term because of the following reasons. We know that diabetes mellitus is a progressive disease, and as the time passes, beta cell function is gradually declining. So we have to augment our treatment. And of course, sedentary behavior of the patient, this also leads to lesser utilization of the available insulin in our body, and hence loss of glycemic control. Prolonged hyperglycemia before treatment is stepped up. So this is also an important point. And high doses may lead to increased adverse effects. So if the monotherapy is given at a very high dose, this may lead to several adverse effects, and this defeats the purpose for which it is being used. And we know that a diabetic patient is having already many comorbidities with them, like diabetes, hypertension, dyslipidemia, coronary artery disease, hyperuricemia, etc., etc. And this factor is also to be kept in mind. And sometimes with the use of monotherapy and patient not being controlled properly, having a lot of symptomatology, there is patient fatigue also, and which also leads to poor adherence of the treatment. So early combination therapy is the demand of the hour, and early combination therapy lowers glycated hemoglobin level faster and provides good legacy effect also. We know that if we control our patients, diabetes patients very well in the early phases of the treatment, this better control lasts in the latter phase of the treatment also, whenever treatment is even discontinued. So this is legacy effect, and for this legacy effect to take, we need to treat our patients with combination therapy and bring about glycated hemoglobin level to target. So this you can see on the left side panel, this is the graph showing this traditional stepwise approach, in which the patient is given an approach of dietary restriction and lifestyle modification. Then monotherapy in oral anti-diabetic monotherapy is started, and sometimes the period is given. Then monotherapy is up titrated. Then this monotherapy is rather for combination therapy is rather then started. when this combination therapy fails, then there is addition of basal insulin, and sometimes even the addition of basal insulin to a regimen of oral anti-diabetic is not working. Then multiple daily insulin injections are required along with oral antidiabetic, and all these treatment are added in a sequential manner, leading to a waste of time and allowing our patients to remain in out of range for most of the time, inviting for the complications of diabetes to set in. So this is our traditional stepwise approach, but now we advocate this early combination approach, and you can see this right side panel showing the good effects of this early combination approach, as the glycated hemoglobin level is brought down to appreciably low level, that is within the target less than 7 most of the time, as we do not wait for longer periods for sequential introduction of all these treatments, and these modalities of treatment are started very early, and so this diet, monotherapy, combination therapy, and oral antidiabetic up titration, they are done and monitored at a very frequent interval, and this allows the majority of patients to achieve this glycemic target. An earlier and more aggressive intervention approach provides more rapid glycemic control and therefore improves patients' glycemic profiles without significantly increasing the incidence of side effects. So this is the nowadays with the use of this combination therapy, we see this scenario. Modes of combination therapy, in combination therapy, we may use combination therapy in a fixed dose formulation, and we may use this combination therapy with addition of individual drugs separately. So advantage of fixed drug combination therapy over individual therapy are increased patient adherence due to reduced complexity of the dosing. There is greater efficacy also, and cost advantage of course is there. And regarding recommendations for use of combination therapy in diabetes, we have our own guidelines of the Research Society for the Study of Diabetes in India, Guidelines 2022, which says that we must consider initiating combination therapy if the glycated hemoglobin is more than 1.5 above the target initial therapy. And dual therapy, it should be a patient-centric approach, and if glucose control targets are not achieved, then we should add sulfonylurea or SGLT2 inhibitor or DPP4 inhibitor or thiazolidinediones or this alpha glucosidase inhibitors or GLP-1 receptor agonist. And individual patient care based on comorbidity. If the patient is having another comorbidity, then this approach should be individualized. It should not be a stereotyped approach, as the patient is maybe having other concomitant comorbidities. So their treatment should be individualized. And regarding this triple therapy, also we must have patient-centric approach. And if glucose targets are not achieved with two agents, start third oral agent that is alpha glucosidase inhibitor or DPP4 inhibitor, SGLT2 inhibitor, or thiazolidinediones, depending on second line agent used, or we may start insulin or GLP-1 agonist peptide also. And International Diabetes Federation 2017 recommendations also says that a second glucose lowering drug should be added if monotherapy with metformin or its replacement is not sufficiently effective to reach the glycated hemoglobin target or fails afterwards. The best choice of add-on is a sulfonylurea, except of course glibenclamide or glyburide. That this is old generation sulfonylurea with longer half-lives, and this has a notoriety to cause this prolonged hypoglycemia, so they are not in use nowadays, and we must use the shorter newer sulfonylurea like glipizide, etc. So the best choice of add-on is a sulfonylurea, then a DPP-4 inhibitor or a SGLT2 inhibitor, and alpha glucosidase inhibitor can be used as well. GLP-1 receptor agonist can be used if weight loss is a priority and the drug is affordable. So if we desire weight loss, then GLP-1 receptor agonist is the drug of choice. The primary care physician may consider patient's profile like age, body weight, complications, and duration of their disease when choosing the best glucose lowering drug to add. So these factors that is of the patient profile must be kept in mind while deciding a treatment glucose lowering therapy for an individual patient. International Diabetes Federation 2017 recommendations also says that a third glucose lowering drug should be added if a combination of glucose lowering drug with metformin is not sufficiently effective to reach or maintain the glycated hemoglobin target. The most common choice to add to oral glucose lowering drug is basal insulin, and GLP-1 receptor agonist can be added instead if weight loss has been insufficient. Triple therapy with 3 oral glucose lowering drugs may be effective before adding an injectable. American Diabetic Association 2020 recommendations also says that if the A1C target is not achieved after approximately 3 months and the patient doesn't have this atherosclerotic cardiovascular disease or chronic kidney disease, consider a combination of metformin and any one of the preferred 6 treatment options like sulfonylurea, thiazolidinediones, DPP-4 inhibitors, SGLT2 inhibitors, and glucagon-like peptide, 1 receptor agonists, and basal insulin. The choice of which agent to add is based on drug-specific effects and patient factors, as we have already discussed. American Diabetic Association 2022 recommendations also says that amongst patients with type 2 diabetes mellitus who have established atherosclerotic cardiovascular disease, SGLT2 inhibitor or GLP-1 receptor agonists with demonstrated cardiovascular benefit are recommended as part of the anti-hyperglycemic regimen. As we have seen that this group of drugs, that is SGLT2 inhibitors, have shown to be bring about a sea change in the outcome of cardiovascular and renally impaired patients in several outcome trials. World Health Organization 2018 recommendations for second-line therapy give a sulfonylurea to patients with type 2 diabetes who do not achieve glycemic control with metformin enrolled or who have contraindications to metformin. And we must introduce human insulin treatment to patients with type 2 diabetes mellitus who do not achieve glycemic control with metformin and or sulfonylurea. If insulin is unsuitable, a DPP-4 inhibitor, SGLT2 inhibitor, or a thiazolidinedione may be added. Diabetes Canada 2020 recommendations says that if A1C values are more than 1.5% above target of diagnosis, initiating metformin in combination with a second anti-hyperglycemic agent should be considered to increase the likelihood of reaching target. So this is the recommendation from Diabetes Canada, which also says that in adults with type 2 diabetes without clinical cardiovascular disease in whom glycemic target are not achieved with existing anti-hyperglycemic medications, incretin agents like DPP-4 inhibitors or GLP-1 receptor agonists and or SGLT2 inhibitors should be considered as add-on medication over insulin secretagogues. So insulin secretagogues like sulfonylurea and glinides, they should be rather not given preference. And thiazolidinediones improve glycemic control if lower risk of hypoglycemia or weight gain are the priorities. Now we will just focus our attention on the availability status of the fixed dose combinations, and we know that we have this FDC available in many fixed dose combinations Of course, metformin forms a part and parcel of all these combination regimens, being the initial drug of the choice to start a therapy in a case of type 2 diabetes mellitus. So, metformin provides the pivot, and other drugs are added on it in this combination. So metformin plus sulfonylurea like glibenclamide, glipizide, glyclazide, and glimepiride. And we have already discussed that older generation sulfonylurea like glibenclamide are not preferred nowadays. Rather, we should be concentrating more on the use of glimepiride and glyclazide. Metformin, along with DPP4 inhibitors like sitagliptin, lina, sexa, gemagliptin, teneligliptin, and vildagliptin, they are also in fixed dose combination. Then metformin, along with SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, and remagliflozin, they are available with us to treat our diabetes mellitus patients. And other available dual FDCs are metformin with glitazones, pioglitazone and rosiglitazone. As we all are quite aware, rosiglitazone is not finding favor with physicians due to its side effect profile, and nowadays this is almost not being used. So pioglitazone remains the only glitazone that is being used along with metformin in fixed drug combinations. And metformin with alpha glucosidase inhibitors like bogligos and acarbose, they are quite frequently used. As we know that alpha glucosidase inhibitors inhibits the absorption of disaccharides from the intestinal, leading to postprandial glucose control. And then the other combinations of other than metformin, that is DPP4 and SGLT2, these are also now finding favor with the physicians, especially in those patients, those subsets of type 2 diabetes mellitus who are having either risk for this atherosclerotic cardiovascular or renal diseases or established atherosclerotic cardiovascular diseases. In those conditions, the combination of DPP4, especially linagliptin and SGLT2 inhibitors in the form of empagliflozin and dapagliflozin is finding favor. Anti-hyperglycemic fixed drug combinations approved by the DCGI. This table provides a summary of all those. You are all quite aware with these formulations. I will not go into the details. But of course, the mechanism of action of metformin, various drugs in the combinations, we must also rather refresh our memory. So metformin suppresses hepatic gluconeogenesis and reduces fasting glycemia and increases peripheral glucose utilization. And we all know sulfonylureas being a secretagogue, it stimulates pancreatic beta cells to increase the insulin secretions from the pancreatic beta cells. Thiazolidinediones and biguanides, they increase insulin sensitivity in the liver and adipose tissue and inhibits beta cell loss. So they are favorably placed in the especially in obese type 2 diabetes mellitus patients. And rationale of using these drugs are that they provide synergistic effect and decrease side effects. And so far as thiazolidinedine and biguanides fixed drug combinations are concerned, they provide synergistic effect, provide as late add-on therapy, and reduces weight gain. And risk, of course, we have risk of hypoglycemia and weight gain with the use of sulfonylurea in any fixed drug combinations. And thiazolidinediones have this propensity to cause fluid retention and limb edema. So this thiazolidinedione group of drugs should be used with a caution in cardiovascular compromised patients. And other combinations like the DPP4 inhibitors and biguanides, we know that DPP4 inhibitors, these drugs act by inhibiting the breakdown of GLP-1 by this DPP4 enzyme, therefore increases GLP-1 levels, and increased GLP-1 level results in increased glucose-dependent insulin release from the beta cells and decreases the level of circulating glucagon also, and hepatic glucose production is also kept in check. So this has a very novel mechanism of action, and the action of this group of drugs are glucose dependent. So there is less chances of causing hypoglycemia. And meglitinides and biguanides, we know that meglitinides are also a secretagogue, and this controls postprandial hyperglycemia. They have short duration of action, so they can be used as a mealtime drug also. And alpha glucosidase inhibitors and biguanides, they block this AGI group of drugs, alpha glucosidase inhibitors. They block oligosaccharide catabolism and reduces intestinal glucose absorption, thus controls postprandial blood glucose. So whenever postprandial hyperglycemia is a concern, we may use this alpha glucose inhibitor and biguanides. And rationale of using these drugs is itself clear from their effect mechanism of action profile, and they provide synergistic effect. Beneficial effect is seen in early aggressive therapy, and with the use of DPP-4 and biguanides, there is no weight gain and hypoglycemia is rare, and vildagliptin reduces free fatty acids level, but linagliptin is safe for use in renally compromised patients. So mostly in renally compromised patients, this SGLT DPP-4 inhibitor linagliptin is rather used very frequently and in an increased manner. Meglitinide and biguanides, they provide synergistic effect, and this alpha glucosidase inhibitors and biguanides, they also provide synergistic effect. And risk, we all know that DPP-4 inhibitors and biguanide have some gastrointestinal adverse effect. Meglitinide and biguanides combinations, the renal functions should be assessed before starting these therapies, and there is some chances of having this metabolic acidosis, so these complications should also be kept in mind. Regarding the combination, fixed drug combination of alpha glucosidase inhibitor and biguanides, lack of tolerability in patients who complain of gastrointestinal symptoms. So gastrointestinal symptoms sometimes warrants a patient to stop this treatment with AZI group of drugs. Then combination of biguanides and SGLT2 inhibitors, we have dapagliflozin with metformin, empagliflozin with metformin in several formulations, several strengths, and they increase they act by increasing renal glucose excretion. We know that this group of drugs inhibits the reabsorption of glucose from the proximal convoluted tubule, and thereby promoting this glucosuria and bringing about this reduction in the hyperglycemia. And their rationale of use is that they are providing synergistic action. They reduce weight gain and blood pressure. So though in those individuals who are obese and who are hypertensive, these combinations are especially suited. And risk factors, as is true with any SGLT2 inhibitor, as there is glucosuria, so there is an increased risk of urinary tract infection and genital tract infection, especially genital mycotic infections, to be kept in, just to kept a watch on the on these symptoms. SGLT2 inhibitors and DPP-4 inhibitors, empagliflozin and linagliptin are rather used very increasingly nowadays due to their favorable additive actions, and they increase renal glucose excretion and increase glucose-dependent insulin release and decrease level of circulating glucagon and hepatic glucose productions. They provide synergistic effect, reduce weight gain and blood pressure, and reduce cardiovascular risk factors or risk also. And as earlier told, with the use of SGLT2 inhibitor, this UTI and upper respiratory tract infections with the use of DPP-4 inhibitors sometimes pose and sometimes this nasopharyngitis is a problem with DPP-4 inhibitors. Thiazolidinedione and sulfonylurea, we have a combination of pioglitazone and glimepiride. this Rosi and glimepiride are no longer very frequently used. And this thiazolidine, as we have already discussed, they increase insulin sensitivity in liver and adipose tissue and inhibits beta cell loss. So their profile-wise, they are very suited drugs, especially, but they have a propensity to cause peripheral edema. So their use in congestive heart failure should be discouraged. And this osteoporosis and moderate weight gain is also there. So in those cases, these drugs should not be used. Let us talk about the available triple fixed drug combinations in diabetes mellitus. Along with metformin, we have glimepiride as sulfonylurea and this voglivose as alpha glucosidase inhibitor triple combination. Then we have metformin, sulfonylurea and glitazone combination. So these two combinations are very, very frequently used in day-to-day practice or day-to-day treatment of the type 2 diabetes mellitus, and they are found in great favor with the physicians also with the use of administration, and they are finding favor with patients also as they have less pill burden and compliance is better. So these are the different combinations. You all are quite conversant with their use, and we have already discussed their individual mechanism of actions and their side effect profiles. So I will not waste my time on those. This is a study from three major cities, two in our own country and one in Nepal, Kathmandu, New Delhi, Guwahati and Kathmandu, where clinical practice pattern was evaluated in the management of type 2 diabetes mellitus. And as you can see that these parameters were studied, that is preferred second line oral agent after metformin, then preferred third line oral agent, then preferred fourth line oral agent, preferred sulfonylurea in clinical practice. So you can see this sulfonylurea as a preferred second line oral agent was seen in New Delhi, that is 37.54%, Guwahati 80% and Kathmandu 80.82%. So, and preferred third line like AGI and sulfonylurea, different percentage as you can see, city-wise. This is a study carried out over 3 cities. And measures to prevent irrational and promote rational fixed dose combination. This is a very important point to keep in mind while using FDC. So we must prevent irrational use and rather promote rational fixed dose combinations. A multi-step approach is required to prevent irrational FDCs. So what is irrational? We have already discussed that those the FDC should have rather additive effect. They should rather have synergistic effect. Their side effects profiles should not be rather added. Their toxicity should not be rather added. So these are the rationality for use in FDC formulations. And a multi-step approach is required to prevent irrational fixed drug combinations, ensuring good pharmacovigilance practice, ensuring scientific rationale to develop fixed drug combinations, ensuring good prescribing and pharmacy practices, and strengthening the enforcement mechanism by regulators. So this is also very important. A regulatory control must be there, who should watch the prescription pattern and analyze and rather come out with their recommendations from time to time. And training medical and pharmacy students and doctors with regular CMEs on drug information. This is very, very important to keep the treating healthcare practitioners regarding the use of various drugs. Of course, we have some barriers also to this effective glucose management. Despite all this, there is ineffective diet and exercise initiatives. There is delayed efficacy due to a slow traditional stepwise approach, as we have seen that in the sequential approach we lose valuable times and allow our patients to remain in hyperglycemic range most of the time, inviting the dreaded complications of diabetes mellitus to set in. So, and there is of course suboptimal healthcare systems impede achievement in a glycemic goal also. And sometimes physician inertia is also there. Physicians are reluctant to up-titrate the doses and rather use various combinations therapy for the fear of causing hypoglycemia and other adverse effects. So this inertia on the part of physician is also an important point in the barrier to effective glucose management. And lack of perceived efficacy, that is insufficient communications with the patient. This is a very, very important point, and in all my talk I emphasize on this point that we as a healthcare provider, we must spend some time in educating our patients, and we must explain the different nuances in the treatment of type 2 diabetes mellitus. We must spend some time, we must devote some time in explaining the nature of the disease and what the treatment is likely to give them, and how they are expected to behave regarding their treatment and regarding their lifestyle modifications. So these points we must discuss with our patient, at least in our earlier visits. If our patient is a long one in long-term follow-up, then we may not be giving so much time. But in initial visits, we must spend some time. And poor adherence to anti-diabetic regimens is very important, and fixed drug combinations brings about a reduction. We have already seen that 26% reduction in this adherence, risk of this adherence non-compliance is there. And lack of knowledge of underlying pathophysiology. I already said that we must explain the nature of the disease to our patients so that they can accept the treatment modality and follow the treatment regimen that we advise them. And sometimes the inappropriate prescription of medications are there. So this is where pharmacovigilance and this holding of regular CMEs to update the knowledge of the primary care provider is appreciated. And the important steps to get more type 2 diabetes patients to goal, we must aim for good glycemic control as defined a glycated hemoglobin of less than 6.5, and we must monitor glycated hemoglobin every 3 months in addition to regular glucose self-monitoring, and we must aggressively manage hyperglycemia, dyslipidemia and hypertension with the same intensity to obtain the best patient outcome. And we must refer all newly diagnosed patients to a unit specializing in diabetes care wherever possible, and we must address the underlying pathophysiology, including the treatment of insulin resistance. So all diabetics are not same, so we must try to analyze their disease profile, and accordingly we must try to understand their pathophysiology, and accordingly we must advise them suitable treatment. We must treat the patient intensively so as to achieve this target hemoglobin less than 6.5 within 6 months of diagnosis. Because if we control our patients early on, then we will get a legacy effect, which we have already discussed. After 3 months, if patients are not at target, glycated hemoglobin is not less than 6.5, then consider combination therapy. Initiate combination therapy, but regarding this second point, that is after 3 months if patients are not at target, then consider combination therapy. But in certain subsets of population in which there is presence of concomitant cardiovascular renal disease, we should not wait for this period, and we must start those drugs which are suited which are now proven in different outcome trials to effect a rather favorable outcome in cardiovascular and renally compromised patients. So we must initiate combination therapy or insulin immediately for all patients with glycated hemoglobin more than 9% at diagnosis. So this level of hyperglycemia, that is glucose control of this level, that is glycated hemoglobin is more than 9%, we should not wait for this sequential therapy. Rather, we must initiate combination therapy, and even the use of insulin is rather recommended in those individuals. Use combinations of oral anti-diabetic agents with complementary mechanism of actions. Very, very important. Group of drugs, if they have a complementary mechanism of actions, they are rather preferred for the treatment. And we must implement a multi and interdisciplinary team approach to diabetes management to encourage patient education and self-care and share responsibility for patients achieving glucose goals. And the key message of our discussions regarding this fixed drug combinations, we have seen that these drug combinations have merits and some demerits also. We have discussed all those merits and demerits. And reluctance to increased pill burden is a key reason for poor compliance, leading to poor control of glycated hemoglobin level. We have seen that adherence to the treatment, even in the best healthcare system provider countries, their adherence to the treatment is only 39%. So monotherapy is inadequate to maintain the target glycemic level in the long run. Hence, combination therapy is important, and fixed drug combination is better than individual combination therapies in terms of patient adherence, efficacy, and cost advantage. So these are the benefits of a fixed drug combinations. And triple fixed drug combinations offer a reduced pill burden, improved compliance, and better glycemic control. And measures to prevent irrational and promote rational fixed drug combinations is very, very important. So thank you very much for giving me a patient hearing.